Good morning, everybody. My topic for today is traumatic maculopathies. Blunt injuries constitute about 51 to 65% of all the ocular injuries, which either lead to a temporary or permanent visual disability. Majority of the patients are less than 30 years, and 50% of the children who suffer trauma are less than 16 years of age. In all these cases with history of trauma, a detailed history is very important, like how the injury occurred, the nature and size of the instrument which caused the injury, the part of the eye which was involved, that is the time of occurrence of the injury, and what was the vision like before the occurrence of trauma, and how did the vision come down, whether it was a sudden decrease or whether it was a progressive loss of vision. And of course, whether there is any legal environment associated with it. A dilated fundus evaluation after full mydriasis with an indirect ophthalmoscope is a must in all cases of trauma. We also have to look for other associated injuries like choroidal ruptures, retinal, preretinal and subretinal hemorrhages, occult scleral ruptures, traumatic optic neuropathy, retinal tears, breaks, detachments, etc. Commercial retina or Berlin's edema is a very common finding following ocular trauma, especially blunt trauma, which is seen as an area of retinal whitening, may or may not be associated with a cherry red spot, and these changes usually may be delayed by several hours following injury. It could be either a mild concussion or it may result in a severe contusion. Berlin's edema may be due to the pathogenic mechanism is due to the fragmentation of photoreceptor outer segments, damage to the apical portion of the retinal pigment epithelium, acute RP edema and intracellular edema of the glial tissue. In cases of mild concussion, the initial vision may be around normal. The whitening may be less, associated with only very few hemorrhages if present. Clinical changes are usually reversible if they do not leave behind much sequelae, and the final visual acuity is also fairly good in these cases. Angiogram reveals a blocked choroidal fluorescence initially with late RP leak. Whereas in severe cases, it may be associated with defective vision, a dramatic whitening of the retina associated with severe hemorrhages, and the sequelae may be irreversible in the form of pigmentation, scarring, etc. And also there is loss of central visual acuity. Mild cases usually resolve spontaneously with mild RP mottling. Serial OCT guided follow-up is significant and very useful in severe cases of Berlin's edema, where it usually leaves behind visual sequelae in the form of cystoid macular edema, macular cyst, macular hole, RP atrophy and retinal thinning. Trauma also may result in epiretinal membrane formation, which develop at the vitreoretinal interface due to proliferation of retinal glial cells, which gain access through breaks in the ILM. It could be either mild in the form of a cellophane maculopathy, which reveals irregular light reflex or sheen with fine striae and distortion of blood vessels. Or it may be in a severe form in the form of a macular pucker, which shows severe distortion of blood vessels, wrinkling, white striae, and may be associated with pseudo hole and cystoid macular edema. Traumatic macular holes may occur, and the incidence of traumatic macular holes is about 4% following blunt injuries. Several theories have been put forward regarding the mechanism of production of this macular hole, like contusion necrosis with cystoid degeneration, subfoveal hemorrhage, anteroposterior vitreous traction, deroofing of the foveal cyst, etc. Macular hole surgery in a young patient with trauma is a challenging procedure because of the densely adherent posterior cortical vitreous, the absence of posterior vitreous detachment, and the presence of associated ocular injuries. This is a patient, a 30-year-old female patient who presented to us with sudden visual loss following a contusion injury. Dilated evaluation revealed a large subretinal bleed. She underwent Herrick's procedure and underwent displacement of the subretinal blood, and followed with she underwent a fluorescent angiogram which revealed an RP rip. Next entity is a choroidal rupture. This occurs mainly because of the inelastic Bruch's membrane RP choriocapillary complex. It could be either a direct choroidal rupture or an indirect one. Indirect choroidal ruptures are more common, constituting about 78%. It could be either single or multiple, and majority of the choroidal ruptures occur temporal to the disc. It may be associated with, it can be intrachoroidal, subretinal or intraretinal hemorrhage. Choroidal ruptures usually leave behind sequelae in the form of fibrovascular proliferation, RP hyperplasia and scarring, and neovascularization. This is a patient who sustained blunt trauma, who developed a post-traumatic CNVM several months later. Retinal breaks usually result from blunt trauma, but majority of them are limited to the aura. But about 6% of the breaks can occur at the macula also. The video is not playing. This is a patient who had a subialam bleed. She underwent a vitrectomy, and you can see the thick posterior hyaloid. After staining it with triamcinolone acetonide, we are trying to separate the posterior vitreous. The patient was very young. You can see the dense attachments of the posterior hyaloid to the retinal surface. We are trying to separate out the posterior vitreous with the help of the cutter, the flute needle. And it is generally being peeled off with the forceps. After inducing a complete PVD, the ILM is generally peeled with the help of a spatula, and the sub-ILM blood is being evacuated using the flute needle. The remaining ILM is also gently peeled off and the remaining blood evacuated. Follow-up in these cases is very important depending upon the severity of injury, associated collateral ocular damage, the nature and type of sequelae, and also for documentation for medical legal purpose. This is a case I am presenting just to emphasize the need for follow-up in these kind of patients. This patient at presentation had a scleral tear which was repaired, a subluxated nucleus, a subretinal hemorrhage, and you can see a choroidal rupture crossing the macula. And this is the picture after 6 months of follow-up. Developed a retinal detachment. You can see the organized subretinal hemorrhage and a cataract. And this is the post-op picture showing settled detachment, but she has got a scar involving the center of the macula. So the visual prognosis in this case depends upon the associated ocular and retinal damage in the form of traumatic ruptures, macular holes, macular degeneration, traumatic optic neuropathy, etc. And since these cases are prone to develop retinal detachment, cataract and glaucoma later in life, the need for long-term follow-up in these patients must be underscored.